if you're deaf, you're living in a vacuum. Life is not the same if you don't hear what's going on around you. And as soon as I realized there was some sound available, I was desperate on what all the sound I could get. That this was so important to me that I think the first year of the experiment that I drove something like 4,000 or 5,000 miles just to be a part of that. And I would work most of the day, and I would come in, would experiment other time. But as I would hear better and better through that experiment, I would be in every day and quit my job if I had to be part of it. And it just amazes me now that if for some reason I break a wire or something malfunctions, that right away it has to be fixed because I can't live without this cochlear implant.
After I got the implant, then I really felt that I was not disappointed, and just through the stages of getting used to it, I became more confident and really felt that I had made the right decision about what I had done. And from then on, it was just one good thing after another.
Between the time of the surgery to basic guidance, I was preparing myself mentally. I was saying, it's going to be frustrating, but don't give up. Keep fighting. Keep trying to get used to it. When I came to basic guidance, I had such a great time. I mean, it wasn't work. It was fun.
What we'd like to talk about today is the cochlear implant, a little bit about the history of cochlear implants, particularly here at the House Ear Institute. And then we'd like to tell you specifically about the cochlear implant program, how we go about selecting patients, the surgical procedure, something about the fitting and training program, which we term basic guidance, and something about the results. After we've talked about this in general, we will also spend some time talking specifically about cochlear implants in children, since the issues there are somewhat different than for adults. Now, cochlear implants really are not as new as people feel sometimes that they are. Dr. William House began his work here in 1960 and actually did some cochlear implant procedures in 1961. So work developed over the 1960s. And in 1969, William House, working with an engineer, Jack Urban, developed a multi-electrode cochlear implant and implanted it in 3 patients. On the basis of the studies with those patients, and particularly with one patient who spent many hours in the laboratory, a wearable take-home device, single channel, was developed.
And it must have been almost a year after that finally the portable model was finally developed so I could carry it with me. Boy, that was exciting, wasn't it?
Do you remember that first day that you had it and you went out for a bicycle ride when you had the portable unit?
Oh, I remember hearing the kids yelling and playing, talking to friends I hadn't had success talking to at any time. But what I remember the most is the night I took that home, because you and Dave were there and I was trying to get you to talk to me. And it was late, and you were tired, and I wouldn't quit. And we just kept talking. Finally, Dave said, okay, I'll stay up as late as you want, we'll talk.
The cochlear implant actually consists of 2 parts. The portion that is worn outside the body, then implanted surgically. There is a implanted coil which can be stimulated by electromagnetic induction. And the current then goes down into the inner ear and spreads out across the remaining nerve elements of the inner ear. These nerve elements, when they are discharged, give a sensation of sound. This is the actual implanted device. It consists of a little coil of wire embedded in some plastic, and then from that there are 2 wires or electrodes. One is this electrode, which is insulated right down to about 6 millimeters from its end, and then the bare wire of 6 millimeters extends into the inner ear. That's the active electrode. Then there is the return electrode, and the current flows from the coil of wire on down through the tissues and around the nerve endings and then back up to the coil. Now this is the external coil, and it fits right over the internal coil so that the two, through magnetic induction, are held together with the skin interposed between, the skin behind the ear. Then the current actually starts out by being the sound in the environment is picked up by this little microphone, and the current then is transmitted along the wire to this processor where the current is modified electronically and sent up to the external coil, which fits over the internal coil.
So we really date the beginning of our present cochlear implant device and the program that's developed around it as starting in 1973. In that year, Dr. House implanted 5 adult patients representing a wide variety of etiologies of deafness, and we began to develop a clinical program for selecting patients, fitting a prosthesis like the cochlear implant, and examining results over the long term. The cochlear implant program is a multidisciplinary one. It requires, in particular, a cooperative effort between otology and audiology, as well as some interaction with disciplines like engineering. When we get into children, we add a whole variety of other disciplines, such as speech pathology, education of the deaf, psychology, and so on. Over the years, we've developed a clinical assessment battery that allows us to appropriately select candidates for the cochlear implant. This is based on experience over the years with patients and with learning what they can do and what they cannot do with the implant. We then attempt to select the best fit, powerful hearing aid and compare the results with the hearing aid on these same tests to what we know patients with the cochlear implant can achieve. In general, if a patient has a speech detection threshold with a hearing aid that is poorer than 70 dB sound pressure level, they are most likely to achieve more benefit from a cochlear implant. If their speech detection threshold is 70 decibels or better, then we would proceed with some specific discrimination tests, and again, we can compare how the patient performs on these relatively simple closed set or multiple choice tests to what patients with a cochlear implant can achieve. The cochlear implant provides detection of sound across the frequency range tested, from 250 Hz out to 4,000 Hz. Shown here are the average warble tone thresholds for patients implanted to date. Included are their mean unaided responses, their median responses with hearing aids, and their mean cochlear implant thresholds across the frequency range. With the cochlear implant, patients have exceptionally good durational discrimination, that is, timing information, and good intensity discrimination, near normal intensity difference Lymans within a much more limited range. However, they lack frequency discrimination. Frequency difference Lymans for frequencies below approximately 250 or 300 Hz are fair. However, above 750 Hz to 1,000 Hz, frequency discrimination is extremely poor. This combination of elements means that the cochlear implant provides many of the prosodic elements of speech, stress patterns, rhythm, durational cues. On the other hand, the patient cannot understand speech by listening alone. We also consider an important part of the selection and evaluation process the information that is provided to the patient. That is, not only do we select a patient as a candidate for an implant, but the patient selects us. That is, they have to decide whether this is a procedure that they want to undergo. So that part of this evaluation is a discussion not only of their specific audiological results, but showing them the device, discussing with them how it's used, what it might do for them in daily life, how it might differ from their use of a hearing aid if they have experience with that. If possible, we have them meet with another patient who is presently wearing a cochlear implant and using it so that they can ask someone else who has experience, another deaf person, what it is meant for them. And we always ask the deaf patient who is going to serve as a counselor in this situation to be sure and talk both about the positive aspects and the negative aspects. What things do they have trouble with? What does the cochlear implant not do for them? As well as the benefits that it has for them.
When I found out about the cochlear implant on that first visit, the doctor gave me some literature to read. Reading this literature, I became very optimistic about it. I just felt then I would get something at least a little better than being totally deaf. And I just had that feeling all along from what I had read that it just had to be better than not having any hearing at all.
Dr. House has been my doctor since I was a little girl. And when I was 16, he asked for me to have an implant. And I was unsure. I talked to one of the therapists here, Maggie, and she said that she was explaining to me about the implant, and what bothered me most was at that time they used glasses to hold the microphone up there and the coil up there. And they also had this big box, and I feel really uncomfortable about that because I was a girl, I was 16 years old, and very self-conscious of the way I would appear to other people. So I said I don't want to have the implant right now. And then when I was 18, I came back just before college started, and Dr. House asked if I'd be interested now because you didn't have to wear glasses with it. So I talked to several people who had implants, and I feel a lot better about it because those people seem to enjoy having the implant. So I decided that why not? If I don't like it, I don't have to wear it. You know, it's not going to affect me. So I had the implant. I was really glad that I had it because it really made a difference in my life.
If the audiologist and the otologist feel that the candidate is suitable, and if the patient feels that they want to proceed, then the surgical procedure takes place. We normally wait about 2 months following the surgical procedure before fitting the patient with the device and beginning training and use of the device. We refer to this as a basic guidance program. It's not really rehabilitation in the sense of long-term training, but the goals are to fit the device on the patient, achieve the proper adjustments for that individual patient, and to begin training them in care and use of the device, as well as in some basic auditory discriminations. Before the patient leaves the clinic, we would like them to have a good feeling themselves about what they can do with the cochlear implant and what they cannot do with the cochlear implant. They will then gain more experience and perhaps be able to improve some of their performance over time in their daily experience with sound.
The basic guidance was going on, then after when you leave the session, then you're really concentrated on what you are hearing outside, what you are hearing in the environment, what the new sounds are. I remember when someone asked me what music sounded like to me. Well, the first time that they asked, I didn't know what it would sound like. And so I said, well, sing a song. And so these few people sang a song, and my first impression when I heard it was that it sounded like mermaids singing under the water.
Dancing. I love to go dancing. The implant helps a lot. I just put it on one. They have these 3 different levels with the implant. I put it on one when I'm dancing because most of the time the music is so loud. But if I put it on one, I can stand right by the speaker, put my head right there, and I'm fine. Does it hurt? I can hear it. I can hear the bass better, so I can dance to the rhythm better. I remember walking across 3rd Street, and I was walking along, and all of a sudden I hear this siren. I don't know where it's coming from. I'm looking all over the place. So finally it's coming up the street, so I run across the street, and if I didn't have that implant, I wouldn't have heard it. So who knows what would have happened? I don't want to know.
You have wires in your head, you have electronics that you wear, it picks up the sound, and you just listen for sound clues. You convert it to words or whatever kind of sound you're receiving. That anyone is going to respond just according to what kind of thing they hear, just like a person with normal hearing. But you're not picking up as many sound clues, so you do have to be alert to use the ones that you do receive. Sometimes I laugh about it because when I became a librarian, all we dealt with were things like books, magazines, and newspapers. And all of a sudden I find out that I'm responsible for tape recorders and record players, film projectors. about the time that I think, gee, that's really doing a lot. All of a sudden that I find that we're doing things with video. So there's much more now that we're doing with different kinds of communication where you're listening to it. It's not just reading.
We presently ask our patients to return at least once a year to the clinic for a complete post-implant audiological evaluation. On this basis, we can determine what the benefits of the cochlear implant are, ascertain that that particular patient's device is functioning well and that they are obtaining the maximum possible benefits. And we can also look at the long-term safety issues involved. To summarize what we feel now, based on this data, the cochlear implant provides auditory thresholds across the frequency range at approximately 55 to 65 decibel sound pressure level. Patients can detect many environmental sounds, particularly most medium and loud sounds, and given context can learn to identify many of those sounds. In addition, they can hear voices, both their own voice and those of others. In terms of their own voice, this can help them greatly in their voice production. And in terms of listening to other speakers, it can add cues that will greatly aid lip reading, providing considerably improved speech communication for many patients. All of these things add up in ways that are very difficult to define quantitatively to considerable improvements in quality of life. Given these benefits, what are the safety issues? Well, there are now nearly 400 patients who have been implanted with this single electrode cochlear implant on a worldwide basis. We now have something approaching perhaps 3 million hours of electrical stimulation in humans. We have approximately 20 patients that have been wearing a cochlear implant device on a daily basis for more than 5 years, and we have one patient who has been wearing a cochlear implant for nearly 13 years. Given this considerable experience, both in terms of numbers of patients and long-term history, we've had remarkably few measurable adverse effects. There have been no significant surgical or post-operative complications, and we've seen only very rarely any change at all following surgery or following electrical stimulation and any other common otologic symptoms such as tinnitus or dizziness. In 1980, given the good results that we had obtained with adults, we felt it was time to consider the cochlear implant for children. So late in that year, 3 older children, a 10-year-old and 2 teenagers, were implanted. In early 1981, the first preschool-aged children were implanted, and during the course of that year, we implanted approximately 12 children as a pilot study to develop a program and to determine whether we felt this was an area that we should pursue. Now, the potential benefits for children are in many ways even greater than those that we would consider for adults. Probably the primary area for potential benefit with profoundly deaf children is in the area of development of oral communication skills, in particular things such as speech production. Also, we have to keep in mind that sound provides one of the primary sources of information about events that are occurring in the environment, and this is very important in the early life of a child in the development of cognitive skills. Finally, there is some reason to believe that early stimulation of the auditory system might help to prevent the degeneration that we know is likely to occur if auditory input is not received. Obviously, potential benefits must be weighed carefully against potential risks. The risk of primary concern right now seems to be that of whether cochlear implants might in some way further damage the remaining auditory system. This could happen through either of 2 means, either by damage directly from the electrical current itself, that is the effect that it has upon tissues of the inner ear, or through trauma to the cochlea during insertion of the electrode. Although there's no way to say for the long term what the results might be with the cochlear implant, there's no evidence to date that makes us feel these are significant risks that outweigh the potential benefits of having sound now, particularly for the young child. Several other areas of concern are those of otitis media and skull growth, 2 things that are different in the child than in the adult. Otitis media is frequent among hearing-impaired children, and the question is whether this infection could spread along the electrode to the inner ear and result in a more serious disease such as meningitis. Again, we have no evidence to date that this is a serious risk, The issue of skull growth is also one that to a certain degree is unknown. However, the two children who were implanted at a preschool age in 1981 have now had their cochlear implants for nearly 4 years. In neither case has there been any change in functioning or any indication that the electrode has in some manner been pulled from the cochlea. So that we feel neither of these issues, otitis media or skull growth, are significant enough risks to outweigh the potential benefits of the cochlear implant. The selection procedures for potential cochlear implant candidates among children are very similar to those used for adults. The issue is the same. Can the child do as well with a conventional hearing aid as they are likely to be able to do with a cochlear implant, or is there a likelihood that the implant will provide them greater benefit? Testing children, on the other hand, is much more difficult than adults. Therefore, we have defined our lower age limit for children to be 2 years old, the age at which behavioral audiometry can be obtained. Now, in the case of children, we are starting our program with the extreme range of deafness. That is, 80 to 90% of the children implanted have no measurable responses, even with hearing aids, at frequencies of 2,000 hertz and higher. And a very significant proportion of them have no measurable response with hearing aids, even at 1,000 hertz. Therefore, these children are extremely deaf, and this makes the determination of suitability for the cochlear implant somewhat easier. Once a child does undergo the surgical procedure, we wait approximately 4 to 6 weeks, and they then return for the basic guidance program. Again, the goals are similar to those of the adult program: to fit the device on the child, to obtain the best possible settings, and to begin some basic training in care and use of the device. Obviously, in the case of children, a good portion of the basic guidance program is directed at the parent. And parent counseling provides the parent with information regarding care of the device, how to troubleshoot it to determine whether it is working effectively as it should be for the child, and shows them the beginnings of what the child might be able to do with the implant and what they clearly cannot do with the cochlear implant. The audiological results with the cochlear implant for children are similar to those found for adults. That is, they have detection of sound at the same kinds of levels that adult patients do. In addition, some of them show better discrimination than most of the adult patients have yet been able to obtain. Although these patients are very few and are limited to young children who had some hearing and did not lose it until they were 3 years old or older, this does give us some hope that children may be better able to learn to make use of the information provided by the cochlear implant. In speech and language, we have found significant improvements in speech production skills. These include statistically significant improvements in both imitative and spontaneous speech production, and include improvements in the non-segmental areas such as vocal duration, vocal intensity, and vocal pitch, as well as in the production of segmental aspects of speech such as vowels and diphthongs and simple consonants. We have assessed the children at 6-month intervals following cochlear implant. Here's an example of the kinds of changes we have seen in speech production for one particular child.
Ball. Good job. What's this? Car. That's right. Airplane. That's right. What's this? Shoe. Good job.
In this pre-implant speech and language evaluation, Matthew consistently used signs. However, he only produced vocalizations about 40% of the time.
That's right, it's a ball. Good boy. What's this? What is it? Car. Good boy. What about this? That's right, airplane. Very good. Your speech is terrific. Shoe. Very good.
6 months after being fit with his implant, Matthew is vocalizing consistently and has shown improvement in his speech production skills. He has even begun to drop signs on occasion. At this point in time, nearly 150 children have received the cochlear implant. They've ranged in age from as young as 2 years, 5 months, to as old as 17 years, 11 months. On the average, the children implanted are 8.5 years old. In addition, they differ greatly in their etiology of deafness and age at onset of deafness. Nearly 2/3 of the children implanted were deafened by meningitis, but they may have been deafened as young as several weeks or several months of age to as old as 5 or 6 or 7 years of age. They also differ in their educational backgrounds and their communication methods. We have children in total communication programs, children in oral-oral programs, children in auditory verbal programs, and children who use cued speech. Therefore, the benefits of the cochlear implant have to be determined specifically for this wide variety of types of children. We cannot at this point in time say what the long-term effects, either in terms of benefits or in terms of potential risks, might be for children who receive the cochlear implant. But we have seen to date no adverse effects and very significant and consistent benefits across a wide variety of children.
I'd like to also welcome you all here and thank you for coming to the House Ear Institute in Los Angeles. Today is a very exciting day for all of us. Today, the FDA announced approval of the House 3M cochlear implant device. This is extremely important, and what I would like to do is to read a statement that my uncle, the developer of this implant, read at the FDA headquarters in Washington, D.C. this morning. The FDA approval for use in adults of the 3M cochlear implant developed by the House Ear Institute and manufactured by 3M of St. Paul, Minnesota, has broken the barrier of deafness which has plagued men, women, children for thousands of years. The technological advancements of the past 10 years and the assistance of the 3M Corporation of Minnesota have brought us to the point where the 3M House cochlear implant is an accepted form of treatment for the totally deaf.
Cochlear implants are here to stay. They represent a significant benefit to a select group of profoundly deaf patients for whom there was no appropriate alternative in the past. It is a unique situation that now faces audiology and otology because cochlear implants require teamwork. They require both otology and audiology to work together in providing the greatest possible benefit for patients.
I really feel that it has done a whole lot for me in being able to be sociable and to be able to communicate with others, and it just takes away all that frustration that I remember experiencing after I had lost all of my hearing and wondering what I was going to do with my life now. And now with the cochlear implant I find out what I am able to do.
Before I got it, I never thought that it would make this much of a difference, but after I was wearing it, it was really fascinating. It was kind of like a learning experience for me because it's more like I can get more involved in the hearing world. And so that's kind of like where I grew up. And so when I lost all my hearing, it made it harder. And then when I sort of got it back with the implant, I just joined back in the hearing world again.
I think that when you're completely deaf, people might want to communicate with you. They don't know how. They probably don't even know how to try. As soon as you're communicating successfully, all of a sudden people open up to you and you are in communication with them. I think maybe when you're back before you have any hearing, the people may be a little afraid of you, the failure of trying to communicate. And all of a sudden that they know that you can communicate, and then you have this much better empathy that results.